we're starting with chapter 33, diuretics. So yesterday we talked about the drugs that are used to treat hypertension. And although diuretics wasn't fully listed and discussed in chapter 35, we did kind of say we're going to use these drugs to treat hypertension. So we're using diuretics to treat a number of different disorders and diseases. And so we're just going to, as a nurse, your job is to know how they work. And your job is also to know what to expect in regards to your patients, like what should you be monitoring. So that's one of the things that no matter what drug we're talking about, your depth of understanding needs to be enough to know what to look for in your patient. You know, if you just on the most basic, if your patient's on a diuretic, you're going to expect them to urinate more. So if their urine, if they're on their diuretic and their urine, their output is significantly decreased from the norm, that should send off a red flag, you know, something that you really need to be looking for. So just knowing what to expect as a nurse is going to make you a better nurse, and it's going to make your patients safer in regards to medication administration and monitoring. So, diuretics. So everybody knows what edema is? Thumbs up. Edema is the accumulation of excess water in the body. Swelling of the extremities. Have y'all learned about pitting edema, non-pitting edema? So edema is just that accumulation of excess water in the body. We also call it fluid retention, and it's often associated with heart failure, corticosteroid or estrogen therapy, and cirrhosis of the liver. Those are the three main causes of edema. Sometimes, you know, there's other causes, there's additional causes, but those are when somebody has, you know, pitting, real deal edema, those are usually the causes. Doesn't mean if your legs swell after a long day that you have heart failure, but at the end of the day, those are the three main things. So let's just, if we know that those are reasons for fluid retention, then we know that those are also going to be some of the reasons that our physicians are going to prescribe diuretics, correct? Because we're going to want to get rid of some of that excess fluid. So when edema is present, the doctor may prescribe a diuretic to reduce the increased fluid. I just said that, sorry. Diuretics increase the excretion of urine by the kidneys, and they work by altering the excretion or the reabsorption of sodium and chloride in the kidneys. So we know at the end of the day, do y'all remember A and P, or did y'all just learn it to pass the test? How much do y'all remember about the kidneys? Not as much as I want for y'all to, kind of, sort of. Ish. Do y'all remember anything about tubules or glomeruli or anything like that? Okay, so at the end of the day, the kidneys, the filters within the kidneys they're our sensors. They're either pulling stuff back into our blood or they're pushing it out through the tubules for excretion, right? Their job is excretion. So what they normally would do is they would pull what's needed back into the bloodstream, because we want to keep those levels. Y'all are learning in your, what is it, Med-Surg 2? Y'all are learning what, excuse me, what the normal levels for sodium are, and you're learning the signs of hyponatremia and hypernatremia. So the body's job, the kidney's job in homeostasis are to keep those levels of sodium and chloride within the blood normal and excrete the rest, correct? We would all kind of agree that that's the kidney's job in homeostasis. So the kidneys, in a normal function without any interference, they're either gonna hang on or they're gonna excrete. So just like we talked about yesterday when we talked about hypertension and we talked about the body's normal ROS system, we said our medications interfered somewhere in that process, right? Something's got to bind to a receptor or something's got to trigger a response in order for that medication to be effective. We're all on the same page right now, correct? So right now what we're going to talk about is how do diuretics trigger the body to do something different? How do they trigger the body to pee more? How do they trigger the body, to get rid of excess sodium and chloride? And sometimes they tell them to hang on and then you still pee. So those are the different types of diuretics that we're talking about. So I'm going to read that statement again now that I kind of explained that a little bit. Diuretics increase the excretion of urine by the kidneys and work by altering the excretion or the reabsorption of sodium and chloride in the kidneys. So water is going to follow those solutes, right? It's going to move from an area of, it's going to move to the area that's more concentrated with more salt, and it's going to move by osmosis to that area. So let's talk about it from here. So for our diuretics, we have different types. So the little, when we were talking yesterday, the umbrella is diuretics. We have loop diuretics, potassium-sparing diuretics, thiazides and related diuretics, carbonic anhydrase inhibitors, and osmotic diuretics. Those are the 5 subclasses underneath diuretics, okay? So if you're making a little word map, y'all are gonna get so sick of me talking about word maps. I made one. I don't know where it is though. I'm gonna post all these for you when all the lectures are done because I don't know where I put it. But if you're making a little word map, diuretics, loop, potassium sparing, thiazide, carbonic, and osmotic diuretics. Those are your subclasses. All right, loop diuretics. The most common loop diuretic is Lasix. Raise your hand if you've heard of Lasix. Lasix is one of those drugs. I don't always make y'all memorize both generic and brand name, but you need to know it for Lasix for sure. Because very rarely are patients going to say I'm taking my furosemide. They're going to say that they're taking their Lasix. So you need to know that furosemide and Lasix are the same thing. So Lasix is the most common type of loop diuretic. Others are torsemide and butanamide. That's Demodex and Bumax are the other names for those. And the way that they work is that the medication causes your body to inhibit the reabsorption of sodium and chloride. So if it's inhibiting the reabsorption back into the body, that means it's pushing it for excretion, and then the urine is following. Does that kind of make sense to everybody in very simplified terms? Instead of being reabsorbed, we're pushing it back out for excretion. So we're gonna excrete sodium and chloride, and with loop diuretics, you're also gonna secrete, or I say secrete, you're gonna excrete, you're gonna get rid of potassium. So before we move on, and I want y'all to type this in the chat bar, and I want y'all to communicate with me. Just based on what I just told you, a patient on loop diuretics, what are we monitoring in their labs? And you can say it out loud if you want, or you can type it in the chat bar. I don't really care.
Their potassium levels?
We are absolutely monitoring their potassium levels if they are on a loop diuretic, because we are getting rid of the potassium. And then we're also going to be looking at their sodium and chloride levels, right? But potassium is, if we're excreting it, then we're going to be monitoring it. If potassium is too low, what does it primarily affect? Your heart. Potassium has a big, big effect on your heart, okay? So as a nurse, it is very important that we know our patient's potassium levels. Are we giving Lasix if our patient has a potassium of 3.0? What you think? We surely are not. We're not. We're calling the doc, okay? And we're probably going to start them on some kind of potassium supplement. Okay, before we move on, I want to highlight stuff that y'all already know, so you're not getting overwhelmed with what you don't know. As a nurse, outside of supplements, what is something that you can educate your patient to do if their potassium is low?
Put it like in their, or I guess put it in their diet.
Absolutely. You're going to have your patient. I'm glad Kat's talking to me today. Thank you, Kat. You're going to have them, you're going to supplement it into their diet. And let them know, when you're taking these medications, your potassium could be low. It could cause your potassium to be a little bit on the lower end. You're going to educate on the foods that are high in potassium, right? All right, so you already know at the end of all of these slides, we talk about the nursing process. So you have already told me some things you're going to assess, and you've already told me some things that you're going to implement, right? So we know what to do as a nurse. Okay. Next umbrella, I say umbrella, next subcategory are thiazide diuretics. So the way that they're similar to loop. They inhibit the reabsorption of sodium and chloride ions. They just do it in a different portion of, how they have the ascending, the loop of Henle, the descending. It just takes place at a different area of the kidneys with that reabsorption. But at the end of the day, sodium, chloride, and potassium are all excreted. So, are we going to monitor the exact same things for patients on thiazide diuretics? Yes, we are. Thank you, Kelsey. We are going to monitor the same things that we were monitoring before with Lasix. Thiazide diuretics tend to be a little bit less aggressive than, just in my personal, it doesn't say this in the book, but I don't see as much potassium loss with patients on thiazide diuretics as I do on patients, who are on loop diuretics like Lasix and Bumax. But nonetheless, it's still something you need to monitor, okay? Examples of those medications are chlorothiazide, hydrochlorothiazide. Have y'all heard of HCTZ? That hydrochlorothiazide is often abbreviated HCTZ. And chlorothialidone. We feel okay moving on? All right, now the next one that we're talking about, they are potassium sparing diuretics. So if they're sparing potassium, they are saving it. We're not excreting it with these diuretics, okay? Potassium sparing diuretics reduce the excretion of potassium from the kidneys, and they block the reabsorption of sodium in the kidney tubules. So they are still interfering with that sodium reabsorption, but they're specifically reducing the excretion of potassium. They're saving it. They're reaching out and saying, nope, you're not going with. You're staying right here in the blood. So if we have a patient on a potassium sparing diuretic, what might we expect to happen with their potassium levels? And I want everybody to give me either a thumbs up. Are we expecting them to go up? Or are we expecting them to go down? If they are on a potassium sparing diuretic, what is going to happen to their potassium? Think about it before you tell me. It's going up. We're saving it. Think potassium sparing, potassium saving, because they're pulling the sodium, the reabsorption of the sodium is, they're blocking that reabsorption. So the sodium is leaving, it's being excreted, but it's like, you think of those potassium sparing diuretics as saying, no, we're sparing your life. We need you in the blood. You're not leaving. Okay, they're potassium saving. So we might expect these patients not to have low potassium, but to have high potassium. This is incredibly important to know, because if you get them swapped up and you're holding their medication, you may be holding it wrong. Like, you know what I'm saying? Like if your patient's potassium is, let's say it's borderline, let's say it's 3.5, okay? and it's right on the borderline, and we say, oh no, we want to hold their diuretic because we want to hold their potassium sparing diuretic because we don't want their potassium to drop. That would be a poor nursing judgment on your part, because potassium sparing diuretics save that potassium. They don't excrete it. Does that make sense to everyone? Okay, we're going to pause for a second. All right, because I couldn't see all of you guys. So we're going to just pause and recap for a second. What is an example of a loop diuretic? The most common loop diuretic that I told you.
Lasix.
Lasix, yes. Lasix, what's happening? Are we holding on to potassium or are we peeing it out?
Excreting it.
We're excreting it, yes. We're getting rid of our potassium when we take Lasix. Spirolactone is the most common. Okay, so that was loop. Now I'm moving on to potassium-sparing diuretics. Spirolactone, or aldactone is the other name. That is the most common potassium-sparing diuretic. Okay? And I just remember things weird. I think, K is the symbol for potassium. I think spirolactone, just like say it like that in your head and you'll remember that it's saving the potassium, okay? Like be a little spazzy and say spirolactone or aldactone and you'll know that it's hanging on to that potassium. Those are absolutely drugs that you need to remember forever, okay? And then there was one other class that we talked about so far. What was it? Yes, thiazides. What is the most common thiazide diuretics? Anybody remember? It's my favorite drug name to say. I don't know why. Hydrochlorothiazide, HCTZ. It's fun. Y'all should all say it. I know it's 8:30 in the morning, but hydrochlorothiazide makes you sound smart. Until I figure out that I'm saying it wrong, at however old I am. I'm not going to reveal that. All right, so we already are down 3 subclasses of diuretics. Yay? Feel okay? Ready to move on? Cruising? Okay. So, also want to pause and tell you, remember we said that they affect the blood pressure? So, if our blood is less concentrated, it's got less salt, it's got less solutes in it, and it's got less, I hate to just say pee, but we're peeing out a lot of that excess fluid. Our vessels are not as jam-packed with fluid, so it would make sense that diuretics would bring our pressure down. Yes? Yes. So they're often used as a double-edged sword. They're fixing those fluid imbalances, and they're also bringing pressure down. So you're going to see a lot of your patients on diuretics. All right, back to the PowerPoint, if I can figure out how. All right. I don't know why it won't just let me go back to it. Hold on, I got to pull up the whole PowerPoint again. But I like to see y'all when I talk to y'all. Okay. We said that let me take a little sip here. All right. So we can have fluid buildup other places than just our vessels, right? Would we all agree that we can have fluid buildup elsewhere? So at its most simplified, I guess the most simple way I could explain it, glaucoma is fluid buildup behind the eyes. It's basically high blood pressure behind the eyes, okay? So carbonic anhydrase inhibitors are going to treat that, they're going to be used to treat glaucoma. They're going to decrease the production. So they work differently because they're not working with the kidneys and the tubules like our other diuretics were. They decrease the production of aqueous humor in the eye, which in turn decreases intraocular pressure. So, and basically they kind of work in the same sense, except they're targeting. Remember we talked about how the body has different areas that the body has normal receptors within it. We know where this targets this, and our medications are made in such a way that they can target those places and interfere with those normal homeostasis processes. The carbonic anhydrase inhibitors kind of work the same way as the others, but they have a different target site. They're targeting the aqueous humor in the eye. Does that kind of make sense to you guys? So they're decreasing pressure behind the eye. And examples of those medications, let's see, can be found on page 380. So basically they're for intraocular pressure, not high blood pressure. And then the last group of diuretics are osmotic diuretics. So we can have pressure in our vessels, peripherally. We can have pressure behind the eye, and we can have pressure in our brain, okay? So osmotic diuretics increase the density of the filtrate in the glomerulus. So I want to read a little bit about osmotic diuretics for you. If I can find where I would like to read. Okay. Osmotic and carbonic anhydrase inhibitors are used for treatment of cerebral edema and seizures, intraocular pressure, and altitude sickness. So those are not medications that you're usually going to be giving. They're usually given in like an emergency type, ICU type setting. And I mean, unless I just haven't come across a lot of these drugs, usually if you have a lot of if you have increased intracranial pressure, there was some kind of trauma or there's some kind of cerebral edema going on and they're trying to figure out, unless you have a birth defect or something, they're trying to figure out what's going on with you. So I haven't given a lot of these medications, to be totally honest with you, but examples are glycerin, isosorbide, mannitol, and urea. And I have not, I want to say I've maybe given mannitol in like a HIOPS years and years and years ago, but those are not nearly as common as all the other drugs that, in a regular nursing setting, as the other drugs that I discussed. So if I gave you all of those diuretics, all of those subclasses, could you tell me what they treat? You think? After you studied them, maybe? Okay, so osmotic diuretics are going to treat, think brain, okay? They're going to treat altitude sickness, which is kind of a strange one. They're going to treat cerebral edema, it's basically swelling edema in the brain. Your carbonic anhydrase inhibitors are treating glaucoma, intraocular pressure behind the eye, potassium sparing, thiazides, and loops are all treating edema, but they have different effects on the electrolytes of the body. We're all still on the same page? Y'all feeling okay?
Did you say that Osmotic cerebral edema.
Yes, cerebral edema in the brain. All right, so I've kind of already told you this. Uses for diuretics, edema associated with congestive heart failure. So with just kind of a little, I know you'll probably all heard the word, but basically with congestive heart failure, the heart is not strong enough to pump all the blood as quickly as it needs to throughout the body. So it kind of builds up. And as it builds up, it starts pushing fluid where it doesn't belong, and edema takes place. Okay, that's like the most simplified version that I could possibly give y'all. So it would make sense that we're using diuretics to get rid of some of that excess fluid, right? Then the heart does not have to work as hard because it's not having to pump as much. Hypertension, we've already talked about. It makes sense that diuretics would be used in renal disease because our kidneys are not functioning as they should and they need a little bit of assistance. We talked about cerebral edema, swelling of the brain, acute glaucoma, that's the pressure behind the eyes, increased intraocular pressure, seizures, and altitude sickness. Those are some of the uses of diuretics. All right, adverse reactions. We've already talked about a few, and they're also going to be similar to what we talked about with high blood pressure medications because it's going to have that secondary effect of lowering the blood pressure. So it could cause dizziness, lightheaded, and this is all of them. Dizziness, lightheadedness, headache, weakness, and fatigue. All of those you can rationalize, right? We're getting rid of a little too much. Have you ever been a little bit dehydrated and felt all of those, experienced all of those things? Cardiovascular reactions could include orthostatic hypotension. Let's see, who I want to pick on? Emily, only because I saw you. What is orthostatic hypotension?
Isn't that where I'm sorry, I'm echoing really bad. Can I type it?
Yeah, you can type it. That's fine.
Okay, now it's saying I can't send a message because I'm not a member of the chat.
Okay.
So I'm gonna try to just say it. I'm not echoing currently. Isn't it where like you something about, I don't know exactly like how to say it exactly, but whenever you like get up too fast or something,
That's perfect.
you're okay.
When you get up and your pressure drops and you feel woozy, that is orthostatic hypotension. So our cardiovascular reactions as related to diuretics are going to be orthostatic hypotension because the same thing is happening when we take blood pressure medications, that we're having a potentially quick drop in that blood pressure and it's causing us to feel a little whoo. And our number one thing, Brendan, that we're trying to do with if our patient is having some orthostatic hypotension, what are we doing for them? What is our priority as a nurse?
Make sure they don't get up too fast when they're laying down.
Yes, safety is always our priority as a nurse when we're talking about orthostatic hypotension. So our patients who are on diuretics have a risk for electrolyte imbalances. Makes perfect sense, right? Because we're altering that. And they have a risk for glycosuria, so they can have some glucose in their urine. Anorexia, nausea, vomiting, hypokalemia, hyperkalemia, gynecomastia, I already said that, hypokalemia and hyperkalemia. All right. Contraindications. We are not giving these medications to patients with a hypersensitivity to the drug. So usually if they don't do well with one loop diuretic, they don't do well with another loop diuretic. So if I told you your patient is allergic to Bumax, or has a hypersensitivity to Bumax, and Lasix has been ordered, what do you think you would do as a nurse? They're in the same class. I'll just tell you that because I know you don't know the drugs just yet. You think we want to just clarify and make sure that the doc wants to do that? Yeah, because they're pretty closely related. So they're gonna be contraindicated in patients with a hypersensitivity to the drug. They're contraindicated in patients with electrolyte imbalances. So we already talked about that. We're not giving a patient with a super low potassium Lasix. Not a good idea. If a patient has severe kidney or liver dysfunction, they're not generally on diuretics. If they have if their kidneys need a little bit of help, the physician might put them on a diuretic. But if their kidneys are just shot, diuretics sometimes cause more damage than they do. It's kind of like pushing a broken car. Like you can only do so much if they're just shot. So as far as kidney, if they have severe kidney or liver dysfunction, they're not going to be on these medications. And if they're not urinating at all, anuria, it means they're not urinating. If they're not urinating, then diuretics aren't going to make them urinate. They're not going to suddenly make them urinate again. Mannitol, that's one of the osmotic diuretics. It is contraindicated in patients with active intracranial bleeding. We're not going to, we don't want to further complicate that. And that's not a call that you ever have to make as a nurse. But things you would be doing as a nurse are checking those pupils, and seeing, what are we doing? We're going to definitely monitor their neurologic status if they are on osmotic diuretics, okay? And then potassium-sparing diuretics are contraindicated in patients with hyperkalemia, and they're not recommended for children. All right. We are going to use diuretics cautiously in patients with renal dysfunction during pregnancy and lactation. We're going to use thiazide and loop diuretics cautiously in patients with diarrhea. We lose a lot of potassium whenever we're pooping, right? Do y'all know that? So if our patients have diarrhea and thiazide and loop diuretics get rid of potassium as well, we're increasing our risk for hypokalemia if we give those meds. And then most medications are used cautiously in patients with liver disease. Why? What does our liver do?
Like filter bile.
Tell me again.
Filters bile.
It does. But in regards to medications, it metabolizes. Whenever y'all don't tell me that, it makes me a little bit nervous. Remember ADME? Absorption, distribution, metabolization takes place in the liver. Metabolism takes metabolism. I can't even get it out. Metabolism is in the liver, or meds are metabolized in the liver. Can't get it out at all. And then excretion. What is our primary site of excretion of medications?
Kidneys.
Yes. Okay. Are y'all just being quiet because y'all don't like talking to me on here, or did y'all don't remember that stuff? You already forgot it.
I remember it. I just, I do, I feel really awkward on here. So
I know it is different being on here than it is being in real class with me. But just sometimes when you don't say anything, it makes me a little nervous. Like y'all don't know what I'm talking about, and I need y'all to know that for sure. All right. So potassium-sparing diuretics, we're going to use them cautiously in patients with liver disease, in patients with diabetes, and in patients with gout. Okay. Okay. Drug-drug interactions. Remember, there's a whole bunch of them. Remember, I showed you all those boxes in the books. Do the best you can with remembering these. But I know that it's a lot to remember. ACE inhibitors can increase the risk for hyperkalemia. And the way that I remember this, some ACE inhibitors have the name like potassium at the end. Like, whenever for their generic name, it'll say, losartan potassium is the name of the drug. So that may help some, but it's just hard to remember. You just have to kind of tuck it away and make some random flashcards. And then NSAIDs, salicylates, and anticoagulants can decrease the diuretic effectiveness. All right, and that's really it for diuretics. We're going to go over the nursing process right here, but we pretty much already talked about it, okay? So you take vital signs and you weigh the patient. I'm going to pull this up on my phone. And we're just going to talk it out. I'm not going to read these slides to y'all. We're going to do like we did yesterday. As awkward as it is, that way I can know that you guys understand, and I'm not telling you what the nursing process is. You're telling me what the nursing process is, okay? I just have to pull it up first. Actually, I can still see y'all. It's okay. So why does the patient's weight matter? Who did I not call on? Kat already said something. Brendan, Kelsey already said something. Emily said something. Essence. Why do you think a patient's weight matters when we're given diuretics? Don't be afraid to get it wrong. Just tell me why you think it matters.
It depends on how much fluid they have in their body. Yes.
So fluid retention is going to be, weight is going to be the main way that we measure fluid retention, right? It is our subjective measurement of that. It's our objective measurement of that, because we can write it down and we can watch it from day to day. If your patient's weight increases 5 pounds in one day, will we say that's significant or not significant?
Significant.
That's significant. Okay, so what might the doctor do in regards to their diuretics? If they're on 20 milligrams, what might we anticipate? If their weight goes up, would we expect their diuretic dosage to increase or decrease? This is where I want y'all to think. I know it's a lot. You don't have to answer it out loud. Y'all can type it in the chat bar. I want y'all to think about it though. If your patient weighed 150 pounds and they were on 20 milligrams of Lasix, and the next day they weighed 155 pounds, would we expect their Lasix dosage to go up to 40 milligrams, or we would expect it to go down to 10 milligrams? What would we expect? What would be the normal response there? That's how I want y'all to start thinking as a nurse.
I would say it would go down.
Why do you think?
I mean, I'm thinking like if their weight goes up, then a doctor would, decrease their dose.
So it's actually the opposite, but I'm glad you at least told me what you think. I would rather y'all talk to me. If their weight goes up, then they're holding on to more fluid. Their edema has increased, right? So what is the job of Lasix is to get rid of that fluid, right? The job of Lasix is to pull that fluid off. So they would need an increased dose or an extra dose. Does that make sense to everybody? Yes, thumbs up, sort of. Need me to say it again? Weight is a very big indicator of fluid retention. Okay. So if your patient gains 5 pounds in a day, you need to call the doctor, Because even though weighing a patient is something super easy, if they gain 5 pounds and then they gain another 3 pounds and then they gain another 3 pounds the next day and it's all water weight, they're in heart failure by the end of the week because their body cannot sustain that amount of fluid. Everybody understands that? Okay. So review the lab results. What lab results are we looking at? Let me see who else I want to see y'all. It's very awkward. It's awkward for me looking at myself. And I can't see you guys. Okay, let's see. All right, Carly, what are we looking for in our patients' labs? What are we looking at?
Looking at potassium, sodium, and chloride.
Yes, ma'am. Yes, ma'am. Everybody understands that? All right. What are we looking for when we check their edema, Catherine B? When we check their edema, how specific? What are we saying about their edema? Like if we're checking, if you were looking at my legs and they were pretty swollen, would you say a little bit of edema, or what would you say? Did y'all learn how to be very?
You said if the edema was like really severe.
Yes.
Is that what you're saying?
Yeah.
Am I echoing?
A little, but it's not bad.
Okay. So it would be like pitting edema, correct?
Yes,
or
pitting edema.
Okay.
And then you would say you can measure that specifically, right? 1 plus, 2 plus, 3 plus, 4 plus. You have to be specific in those documentations because that people always want to keep pharmacology and medication administration separate than the regular nursing process. But that subjective data has a whole heck of a lot to do with their diuretics and how effective they are. Does that make sense to you guys? Yes, maybe. Yeah, okay. All right. Let's see. Go back to my slide. Yeah, it is kind of annoying. Let's see, who else? I'm gonna check and see who else I didn't talk to yet. And then lucky y'all, huh? Then I know Alexia. Is Alexia the only person that I didn't ask a question to yet? I think everybody else talked. And Haley. Okay. Trying to get back to my PowerPoint. Okay, I can't get back to my PowerPoint. All right, so when we are assessing our patient, we know the things that we're looking for. We know the things that we are educating them on. Foods with potassium, we're educating them on, I mean, there's so many things that we can ask them. Their intraocular pressure behind their eye, if we work in that setting. If we're monitoring, if we're giving them an osmotic diuretic for cerebral edema, then we're checking their pupils and we're checking their neurological response. You see how all of those different assessments go with the specific medication that we're giving. I would expect y'all to be able to pick those out as nurses, okay? I'm going to end this recording.